Welcome back everyone. This is the last video of this series on the ERS guideline on long-term home NIV for management of COPD. In this video I will be addressing the last PICO question of the guideline, which was, should we use fixed pressure modes as compared to adaptive or auto-titrating pressure modes when using long-term home NIV in COPD patients? That's actually a very trendy question. NIV modes are either pressure modes or volume modes. During pressure modes, the inspiratory pressure is set, while the delivered volumes will vary according to the resistance of the respiratory system. Conversely, when using volume modes, the inspiratory volume is set, while in that case, inspiratory pressures will vary over time. Accordingly, the physiological advantage of volume mode is the stability of the tidal volume, while pressure modes can compensate unintentional leakages. To date, both modes are reported to be comparably effective, although the majority of studies have provided evidence only for the use of pressure-targeted NIV rather than volume-targeted NIV. Recent developments aim to combine the advantage of volume modes and pressure modes in the same NIV mode. These NIV modes are characterized by a closed loop of ventilation that maintains an operator preset target minute ventilation, independent of the patient's activity. Depending on the mode and the manufacturers, some modes will also be able to adapt a sufficient expiratory pressure for stabilization of the upper airway. In fact, there is a physiological rationale supporting the interest of continuously adapting ventilator parameters because of the upper airway patency variation with body position and sleep stage, or even over the long-term evolution of the severity of the disease. These adaptive or auto-titrating or hybrid modes have been designated to achieve these objectives. There was also the idea behind all of this that such modes would allow implementation of NIV in non-specialized centers where caregivers are not familiar with NIV. In the guideline, 6 randomized control trials have been retrieved, and those 6 trials compared these modes, IVAPS for ResMed and AVAPS for Philips, to classical pressure support modes. These studies were generally not blinded and of a short duration, prohibiting assessment for long-term outcomes, such as mortality or hospitalizations. They demonstrated that the use of these hybrid modes may result of a small reduction in PCO2, little to no difference in oxygenation compared to traditional modes. They also did not improve health-related quality of life or sleep quality. Finally, they did not show any difference in terms of self-reported comfort and objective adherence to NIV between both modes. In light of these informations, the ERS task force suggests using fixed pressure support mode as first choice ventilator mode in patients with COPD using long-term home NIV. Indeed, there is an uncertain risk of harm with adaptive auto-titrating modes, where when there is a severe air leak, for instance, as adaptive modes require the ventilator to accurately estimate tidal volume over time. Thus, low volumes could be delivered in this situation and lead to hypoventilation. In addition, there may be significant extra cost in order to upgrade the patient to a machine equipped with these new modes. And that has to be taken into account. Well, I'm done with this series of video. If you need more details and all the references, of course, I invite you to read extensively the guideline Also, the task force addressed 2 supplemental narrative questions that are, from my point of view, very interesting, like other factors that may impact the effectiveness of NIV in COPD. What are those factors? And the monitoring of NIV in COPD. Thank you very much for your attention and for watching this video, and have a good day. Bye.